Hello, Nutrition 160 students, and welcome to part 2 of Chapter 8. Now, eating disorders is a highlight feature in Chapter 8 in your book, but in teaching this course, I am required to cover it a little more extensively, and I've decided to do a lecture. So this is part of Chapter 8. Now, I want you to know that eating disorders in society, they do occur more commonly in developed nations where food and money are plentiful. Um, than not well-developed countries. Learning to appreciate the uniqueness of oneself may be a key prevention to eating disorders in general. Also, eating disorders are very similar to people who have other mental illnesses or disorders, such as drug addicts, for example, people that are addicted to drugs and alcohol as well are showing similar brain chemistry functions with those that have eating disorders. Now, I want you to know what is an eating disorder. We're going to define it. Eating disorders are very serious but treatable illnesses with medical and psychiatric aspects. So there's a huge medical and also psychiatric aspect to eating disorders. They do coexist with a mental illness, for example, depression, anxiety, or obsessive compulsive disorder. We often see it coexist with these types of mental illnesses. They also have an obsession with food and body weight, body image, and weight. However, it can start as an obsession with food that relates to body image and weight, and it can manifest into something like a coping mechanism, which they use as a way to navigate through negative emotions, similar to how, example, people use drugs as a coping mechanism or alcohol. So it can actually develop into something else other than body image and weight. Early stages of discovering the true understanding of eating disorders. Again, some understanding of eating disorders is maybe some genetic environmental factors. As far as neurobiology, they're studying brain sizes and receptors, and also treatments becoming more promising. I want you to know, as far as the pathophysiology, we don't know yet. We're still we have some early leads, but we are still in the infancy of discovering more about eating disorders. So who gets eating disorders? We often think of women, but I want to also shine light on other populations that I consider kind of like the silent populations. So early males and females from 7 to 8 years old up and up may get an eating disorder, believe it or not, and they maybe start thinking about food already and body image. Most common in females during adolescence and early adulthood, and also some women involved in certain sports where aesthetic is emphasized, like gymnastics, for example, can also cause females to be a little bit more predisposed. Don't forget, though, that men and women in their 30s and 40s and older males and military members are also part of people who get eating disorders. I want you to know that what it's true is that eating disorders are more commonly diagnosed in females than males, and more often during adolescence and early adulthood than older ages. Many cases are also being recognized, so I want you to know, like it's stated here, in men and women in their 30s and 40s and older. Eating disorders affect people of all socioeconomic classes. I also want you to know an important fact that by age 6, girls especially start to express concerns about their own weight or shape. And 40 to 60% of elementary school girls aged 6 to 12 are concerned already about their weight or about becoming too fat. And this concern endures through life, just so you know. So a silent epidemic, I want to shine some light on some of the populations and groups of people that we want to often think of as having an eating disorder. So 10 million males in the US will suffer from a clinically significant eating disorder at some time in their life. And here are some notable factors. So muscularity in the media, compared to the 1970s, I want you to know that the image of a fit muscular man has immensely changed. So it has some impacts as we see here. 33% of adolescent males use unhealthy weight control behaviors. Less likely to get help. Yes, males are less likely to get help according to research, so we have to encourage them to seek help. Higher levels of gender role conflict and traditional masculine ideals. 37% of men who binge eat experience depression. Sexuality, gay males are estimated to comprise 5%, and that's probably has gone up already, of the general population. Among men with eating disorders, I would say more than 42% are now identified as gay. So up to 43% of men are dissatisfied with their bodies, believe it or not, women, okay? I also want you to know that binge eating disorders are more highly prevalent. I want you to know there's something called EDNOS. If you ever see the acronym EDNOS, it stands for Eating Disorder Not Otherwise Specified. And it's a term used by the American Psychiatric Association. And it's also a diagnostic to describe eating disorders that do not meet the criteria for the more strictly defined disorders such as bulimia nervosa and anorexia nervosa. Now, binge eating disorder has climbed up in the 21st century. It's characterized by recurrent binge eating without the regular use of compensatory measures to counter the binge eating, okay? And some of you might have noticed that YouTube for a while had some promoting commercials and promoting short films about binge eating disorder. It was actually not promoting it, but it was promoting people with binge awareness of it, and how Americans have it's a rampant eating disorder that is being seen among Americans. Anorexia nervosa is the first one that I want to cover. It is defined as a serious life-threatening disorder characterized by deliberate self-starvation and the following. So refusal to maintain body weight at or above a minimally normal weight for age and height. So less than 85% expected. Intense fear of gaining weight or becoming fat, even though they're underweight. So they do have this distorted image of themselves. They have a disturbance in the way one's body weight shape is experienced. Self-evaluation and denial is constantly happening in their minds. They also may develop amenorrhea, which is the absence of at least 3 consecutive menstrual cycles or periods for women. Anorexia nervosa does have 2 subcategories. So it's subdivided into the restricting type and the binge eating type. Anorexia nervosa, with the restricting component, the person has not regularly engaged in the binge eating or purging behavior, which is self-induced vomiting or the misuse of laxatives, diuretics, or enemas. Now, a person that is anorexia nervosa with binge eating, the person has regularly engaged in binge eating or purging behavior. I'll give you an example. I actually have experience with eating disorders, but I once worked with someone who had anorexia nervosa, and she would sometimes munch on like little lettuce leaves and little crackers, and she would feel guilty later. She would feel like it was making her fat as it was being processed in her body. So then she would vomit. She would force herself to vomit, or she would try to use laxatives to get rid of the food so she can feel better. Anorexia nervosa implications. So here are some physiological implications. Heart failure caused by slow heart rate and low blood pressure, increased risk for those using drugs for stimulation purposes. We are finding in research that the brain size and receptors of people with anorexia nervosa, when it's very severe, they have cognitive alterations and reduced size in brain cells. Brittle hair and nails, dry skin that may become yellow. They might have mild to severe anemia and blood disorders, swollen joints, reduced muscle mass. They may seem emaciated. Osteoporosis, osteopenia is actually happens before osteoporosis. So it's when we start to see soft or brittle bones. Inability to maintain normal body temperature. And again, osteopenia is when you have weak bones, but not osteoporosis. And again, I want to mention that even though we think of people with anorexia nervosa as someone obsessed with body image, there's also another component that many of us miss, and that is that they're using it as a coping mechanism as well for something. Bulimia nervosa is the second one. It is defined as a serious life-threatening disorder characterized by recurrent episodes of binge eating, usually followed by self-induced vomiting or some form of purging as a means of controlling weight. Now, these people with bulimia nervosa are more harder to detect than anorexia nervosa because most of them that I've encountered can have seem to be of normal weight. Okay, they have this intense fear of gaining weight or becoming fat, even though they are underweight or of normal weight, I should say as well. They have a disturbance in the way one's body shape is experienced. They're also constantly self-evaluating and denying. Patterns are restrictive tendencies followed by high intake of food. So some bulimics, there's different subcategories as well, and they have some things can vary, even though some things are similar, but I've ran into some who will have episodes of hoarding and gorging in food, and then right soon after they feel guilty, so they'll get rid or purge. And then I've also experienced some that also do this hoarding and then purging in order to feel better. And then it's followed along with some episodes where they might starve themselves for a day until they resume the hoarding and purging again. So they may develop more than one pattern, restrictive tendencies as well. Large quantities of food may go missing. I have experience with many bulimics, and I found some of them will hide jars and containers in their bedrooms because that's their personal space. So they'll throw up, they'll vomit in their bedrooms and hide it in containers and jars. Some of them will run the shower as they're in the bathroom in order to muffle the purging, the sounds of vomiting. I've also worked with one young lady who said that when she took showers, she would throw up in the shower, and she would grind the food in the bathtub so that it can go down the hole, and it would often take her hours to shower, and her mother was wondering what she was doing in there. They're very tactful, more than anorexics. They tend to have routines down that are very stealthy and cunning, and they can outwit a lot of people. For instance, I'm just because I have experience in bulimics, but I also worked with another young lady who said that she lived with her mother, her single mother, and her mother was a deep sleeper. So what she would do is she would hoard, she would eat a big dinner to because she was feeling guilty of certain things in her life. Again, she was using this as a coping mechanism. And then she would wait for her mother to go to sleep, and she would sneak out the back door, which was a quiet door, and she would vomit in the middle of the night. So they're extremely tactful. They can go undetected. Vomiting, laxatives, diuretics, and other medications, fasting, even exercise can be used. And again, it can be more difficult to detect. The ease of avoiding detection may keep the athlete or person in denial as well for an extended period. Again, these people appear to be more normal, of normal weight. Bulimia nervosa subcategories, there's the purging type and the non-purging type. So the purging type is the person will regularly engage in self-induced vomiting or the misuse of laxatives, diuretics, or enemas. And then the non-purging has, the person has used other inappropriate compensatory behaviors such as fasting, excessive exercise, but not regularly engaged in the purging behaviors. And then I've also ran into patients that exhibit both. They will alter back and forth. Here are some implications from bulimia nervosa. Erosion of the tooth enamel from the acid produced by vomiting, and also erosion of the esophagus. Inflammation and tears of the esophagus and abscesses can form. I did know someone that had to abstain from eating. She couldn't eat anymore because the abscess had grown so huge in her esophagus. She couldn't swallow food anymore. It was painful. So she had to have it removed. enlarged glands near the cheeks, damage to the stomach from frequent vomiting, irregular heartbeat, heart failure, electrolyte imbalances that can lead to sudden death due to the vomiting, pancreatitis, inflammation of the pancreas, which is a large gland that many of us learned in the digestion and absorption chapter that aids in digestion, and then long-term constipation as well. I want you to know too that because of the nature of getting rid of food involves the digestive system, they are at higher risk for esophageal tears from vomiting, gastrointestinal complications, even during recovery, diarrhea, constipation, irritable bowel syndrome, otherwise known as IBS, dental cavities or caries, and calluses on hands from induced vomiting. Athletes suffering from bulimia nervosa may also have some or all of the general disordered eating signs and symptoms. General disordered eating. So let's talk about some precursors to eating disorders. Now, disordered eating doesn't mean you have an eating disorder, but it can be a precursor or lead to it. And some characteristics of general disordered eating is increased isolation when eating, preoccupation with one's own food, preoccupation with other people's food, ritualistic eating and or avoidance of certain foods, and restrictive calorie intake. I also want you to know some people with eating disorders have disordered eating as well. But again, some people with general disordered eating don't have an eating disorder, but it can be a precursor. I also want you to know that people with eating disorders generally tend to see people normal, just not themselves. When I worked with people that had eating disorders, the patients that I talked to, that I interacted with, when they looked at me, my weight and my height would be considered fat if they obtained it. But when I told them, what do they think about me? Because I weigh what they considered fat, they'd say no, even though, you weigh this much, it looks good on you, you look good, you look fine. So they really don't have any issue with other people's way, of body image wise, of how they look physically, but they do have more of an issue with themselves, okay? Binge eating disorder is one that has gained a lot of popularity and awareness in the 21st century. Binge eating disorder is characterized by recurrent binge eating without the regular use of compensatory measures to counter the binge eating. 75%, you guys, people with BED are overweight or obese and they struggle with weight gain. Note, I want you to know that not all binge eating disorder clients struggle with weight concerns. However, often BED clients have grown up on diet after diet basis, and BED carries the most stigma of all eating disorders. Okay, and here are some signs and symptoms. So eating large quantities of food in a short period of time and feeling great distress and out of control, often done in private or secretly, which I also sometimes see in people with bulimia. High anxiety with having certain foods available. They're very black and white in relationship to food, so it's either a very bad food or a very good food. Food choices hold a moral judgment, like, for instance, I am a bad person if I eat these bad foods. Often BED clients eat very little during the day, and also there can be associations with distress, anxiety, and depression. So binge eating disorder implications, physiologically, let's go through them. So high blood pressure, high cholesterol, fatigue, joint pain, type 2 diabetes, gallbladder disease, again, emulsifying fats. The gallbladder has bile that emulsifies fat. It holds bile produced in the liver until it is needed for digesting fatty foods in the duodenum of the small intestine, but they can develop a disease of the gallbladder, that storage pouch. Heart disease. And for those of you that want to know a little bit more anatomy, the gallbladder is also located inferior and posterior to the liver. So a little bit about athletics and binge eating disorder. I wanted to highlight this. If an athlete's excessive exercise is due to the shame of binge eating, the initial goal is to make the client comfortable in their sport and always staying within the scope of practice. You should initiate a discussion about positive body image. I also want you to keep in mind that a history of failed dieting attempts tends to make individuals with binge eating disorder very resistant to committing to an athletic goal. So also know that if you have athletes with BED, they might have a very hard time committing to an athletic goal as well. Athletic setting signs and symptoms. So again, I wanted to provide a little highlight of athletics. That's one of my specialties. So in the athletic setting, some signs and symptoms can be excessive concern with body aesthetics, prolonged or additional training above and beyond what is required for the sport. Athletes on the team are reporting concerns about the individual, complaints of lightheadedness, and dizziness, decreased concentration, energy, muscle function, coordination, and speed. I worked with an athlete who started to have more fractures and dizzy spells, and I sensed something was wrong. Increased fatigue and perceived exertion, longer recovery time needed after workouts, games, and races, or between workouts, and more frequent muscle strains, sprains, and or fractures as well. What to do if you are concerned about a person or an athlete. So both a person or an athlete. Here are some things. Again, a lot of this is based on my expertise, and then the second half of this lecture, or the last few slides, are straight from your book. So health services, they can help by providing, connecting athletes with a doctor for examination, monitoring an athlete for weight and vital signs, weighing in athletes for weight restricted sports, and then giving a talk to your team as well if you find a doctor that's willing to do it after their hours. And don't try to manage the situation alone. When you help someone with an eating disorder, it should be a comprehensive approach. Next is mental health services. So you can incorporate health services, also mental health services as well. They can help by connecting the athlete to a therapist, talking to the team if there is a designated specialist, informing you of the school's policies on eating disorders, aid in handling athletes who refuse to seek treatment or address problems. Again, don't try to manage the situation alone. Also, like myself, an RD, they can help, which I worked as a sports nutritionist for quite a while. We can give the athlete a meal plan. We can talk to the team about healthy eating for performance. We can also give them our expertise as far as our experience in working with athletes with eating disorders. And then trainers is next. Trainers are part of the treatment process. Trainers and coaches tend to have the best rapport with athletes. So trainers, they can help by having a good enough rapport with athletes to sit a player down and express concerns, giving a talk on the importance of nutrition and strength and endurance building, and giving proper exercise guidance during different stages. Okay, so again, for prevention, we should be incorporating these services beforehand when we are dealing with athletes. Okay, and a lot of these strategies can be also implemented with people that are non-athletes and have eating disorders later. Because at some point they probably want to see like a personal trainer, also regarding exercise, which can be part of later in life when they get over their mental illness, on how to keep a healthy lifestyle. Prevention in athletics, again, because it is my specialty, I want to give you guys information about this. Some things you can do to prevent athletes or support them is be a positive person-oriented coach. Have a coaching style that is positive and person-oriented rather than negative. Performance-oriented coaching style. Social influence and support from teammates with healthy attitudes towards size and shape. So make sure that the team players are all having a social influence that engages and fosters teammates having healthy attitudes towards size and shapes. Okay. Coaches should emphasize factors that contribute to personal success, such as motivation and enthusiasm, rather than body weight or shape. Um, also, treat the concern of an eating disorder similar to other injuries that deter an athlete's health and well-being. So talk to the athlete in a caring and supportive manner, not demeaning manner. Enlist a trusted group of people to help, involve a sports psychologist. There are sports psychologists in the field as well. It's a specialty under kinesiology. You can study that. Um, I also want you to know that from my experience as a sports nutritionist and as an athlete, I've experienced some ways that you can implement these strategies. For example, a lot of volleyball players are considered tall. Um, a short volleyball player might not be a good spiker or blocker, but they can be a great digger and a great defensive player. I myself played volleyball and I am not tall, but I was constantly highlighted on my volleyball team as the person who can dig up any ball. So the opposite team can spike it, I can dig it up, and I can pass it so that my taller teammates can set it up and spike it over. So my role on that volleyball team was to be in the back so that I can dig up all the balls and I can help my teammates out. So I was always voted like the best defensive player. Other athletes that didn't fit the category or the stereotype was, I want to name a few. Usain Bolt is an Olympic and a gold medalist in the Olympics in both the 100-meter sprint and the 200-meter sprint. Sprinters are considered more short and muscular overall. And Usain Bolt is a very tall, muscular man. Now, when I watched him compete in the Olympics, it would take him a lot longer to get up from his blocks than the shorter men. So if it was a 50-meter sprint, he would probably lose. But after he got up with his tall stature, he was on the go and he would usually win the last few meters. Okay. But nonetheless, he is an Olympian, a gold medalist, and he broke the stereotype about how sprinters should look like. Allison Felix is another Olympian. She tends not to be as muscular and short as some of the other sprinters in her category, the females. And I have seen, forgot her name, but there was a gymnast at some point that was on the Olympic team for the US, and she was taller and thinner. And she was an exceptional gymnast, and she broke the stereotype of being a short, muscular gymnast, okay? Again, there's different body compositions and ideal body weights, and I believe that every type of athlete has a certain place on a team. Again, say it right. Never tell an athlete to lose weight. Instead, you can say there are a lot of ways to dance. Let's find a dance style that fits your body instead of trying to force your body to fit a different dance style. The second one can be applied to a lot of my fighters that I used to work with. So you performed and felt better at this certain weight class. Let's consider making that your permanent weight class instead of going down to these smaller weight classes that are stressing you out mentally and physically. So before I cover this slide, I want to go over some more in-depth information for this general prevention. So I talked about athletes, but now I want to focus more on the general prevention of general population. But again, these preventional treatments strategies can be used also for athletes and vice versa. Some of the athletics that can be used for the general population depending on where they are as far as a person. Okay, but in regards to omitting that athletic factor, just in general, these are universal prevention strategies. They are aimed at the general public. Audience usually does not even show any specific risks of developing an eating disorder. When we use the term targeted at risk, are people who are beginning to show signs and symptoms but do not have a diagnosed eating disorder. They can also use these general prevention strategies. I also want you to know we're going to talk about cognitive dissonance. And before I do is I want you to know that people tend to seek consistency in their beliefs and perceptions. So what happens is when one of our beliefs conflicts with another previously held belief, the term cognitive dissonance is used to describe the feeling of discomfort that results from holding two conflicting beliefs. And when there's a discrepancy between beliefs and behaviors, something must change in order to eliminate or reduce the dissonance. So just to break that down, when I talk about cognitive dissonance in this slide, that occurs when a person has a certain belief in their mind that it's a positive belief. They know it's the right belief. For instance, they know they should be eating a balanced diet with plenty of food and calories, nutrients and calories, but their behaviors are not exhibiting that. They maybe have an eating disorder and they're starving themselves. So there's this feeling of guilt because it doesn't match what they're doing and what they believe is not matching. And general prevention is meant to bridge that gap. Okay, so there's psychoeducation based programs, as you see here, which is a treatment intended to teach people about their problem and how to treat it and how to recognize signs of relapse so they can get necessary treatment before their difficulty worsens or reoccurs. And I talked about cognitive dissonance. There's certain psychologists that focus on that component of cognitive dissonance. It's something that psychologists are able to identify in people and then work with them. And again, cognitive dissonance means we're trying to achieve this internal consistency through psychological treatment or prevention strategies because there's an inconsistency going on. Cognitive behavioral-based programs is a treatment that involves 3 overlapping phases. So for example, bulimia has a resistant phase, a procedures phase, and a prevention phase involved to help prevent relapses. Okay. So textbook information, we're going to go ahead and go on to your textbook. These are slides directly from information that is extracted from your text. So these next slides are regarding information that is directly extracted from your book. It enhances the former slides. The former slides were more offered to the class as a form of organizing my expertise in the field. So now I'm using your information from your textbook, the material in there to supplement the former lecture or the former slides. So according to your book, food deprivation and dehydration practices impair physical performance. There's also a condition, it's considered a mental disorder that has very similar characteristics of eating disorders called muscle dysmorphia. And it's also referred to as MD. It's a form of body dysmorphic disorder, BDD. Muscle dysmorphia is actually defined by being preoccupied by worries that one's body is too small or not muscular enough, despite having a normal build, or in many cases, an objectively extremely buff physique. It is a psychological disorder, and again, it's marked by negative body image, as we see in other people with eating disorders. Now, athletes do have good intentions to improve health, but it's there is a certain boundary that they cross and they become obsessive as far as what they're eating and their exercising. And it's very hard to detect because sometimes the eating part is extremely normal, especially with someone who is obsessed with perfectionism in their sport. But when I start to see over exercising along with the eating, some red flags are raised. There's also a term called Anorexia Nervosa that we see in the athletic fields, and you don't necessarily have to know about that for the test, okay? General guidelines for combating eating disorders. I'm not going to read them line by line. I want you to know that I provided the PDF slides for this lecture, and I just want you to read them, but I'm just going to name one. For example, I might ask you on the test, what are some things that you can do to combat eating disorders? You can establish a weight maintenance support group with people who share interests. Here are some other things or tips that you can do, some other strategies. So for example, emphasize nutrition as an important key to optimal performance. treatment of anorexia nervosa. I mentioned some in the former slides, but your book says again it re-emphasizes what I said: multidisciplinary approach, food and weight issues should be addressed, relationship issues as well. I found that many people with eating disorders have relationship issues in their life. With people, different treatment plans based on indicators of malnutrition. There's a spectrum from low, medium, or high risk. Denial. I want you to know that people with anorexia nervosa, and not just anorexia nervosa, but the other eating disorders, they're always in denial, and it will take a long time before they seek treatment. And they will refuse treatment sometimes, just like you see in those intervention shows on TV where a drug addict or the alcoholic walks up and leaves the room because they can't stand the pressure of the people being there that want to help them. And that's the same thing that we see in people with eating disorders. People with anorexia nervosa have the highest premature mortality rate of any psychiatric disorder. So strategies for bulimia nervosa according to your book. Plan meals and snacks. Record plans in a food diary prior to eating. You can plan meals and snacks that require eating at the table and using utensils. Refrain from eating finger foods and refrain from dieting or skipping meals. Okay, but again, they can be hard to deal with because a lot of them will still be in denial. They will still say they don't have an eating disorder or they don't want to hear it. Okay, they don't want to seek help. Nutrition principles continued for bulimics. Eat a well-balanced diet and regularly timed meals consisting of a variety of foods. Include raw vegetables, salad, or raw fruit at meals to prolong eating times. Choose whole grain, high fiber breads, pasta, rice, and cereals to increase bulk. And consume adequate fluid, particularly water. Other tips, you can choose foods that provide protein and fat for satiety and bulky. Fiber-rich carbohydrates for immediate feelings of fullness. Try including soups and other water-rich foods for satiety. Choose portions that meet the definition of a serving according to the USDA food patterns. And again, I put page 40 to 43 in your book. You can go ahead and take a look at those pages. They identify the USDA food patterns. I have found that in a comparison to anorexics, bulimics were a little bit more open to hearing about education. They weren't as resistant. Bulimic nervosa for convenience and to reduce temptation, select foods that naturally divide into portions. Select one potato rather than rice or pasta that can be overloaded onto a plate. Purchase yogurt and cottage cheese in individual containers. Look for small packages of pre-cut steak or chicken and choose frozen dinners with measured portions. Include 30 minutes of physical activity every day, something that they like. Exercise may be an important tool in defeating bulimia, which I found it to be quite true in most of the patients that I work with. Ideal body weight criteria. So this is something that I usually do in my classes for discussion. You can do it on your own, but often I would group you guys and have you guys discuss how a healthy body weight is defined, societal expectations and standards of body image and the criterion for health, and ways for people to accept their body and healthy body, their healthy body weight. Okay. So this is something that I will usually do in a group. You don't have to do it. You're not going to be graded on it, but it's something that if you want to delve into the eating disorders chapter, you can go ahead and do this on your own. And also it helps you implement what you learned in this lecture to see if you were able to retain any of the information and also apply it to this activity, okay?